Welcome back to GUcast. Hey, Renu, how are you?
Hello, Declan. I'm good. Long-awaited podcast.
Yes, it feels like part two, doesn't it? Of a really popular topic that we're going to talk about today, adjuvant immunotherapy for renal cell carcinoma.
Huge paper that's just come out in the New England Journal of Medicine. Big plenary talk at ASCO GU by Toni Choueiri, first author.
Yeah.
It's big news.
It's really big news, and regular listeners or viewers might remember we tackled this topic back in 2021 when the initial paper came out in the New England Journal of Medicine, which was an ASCO plenary, I think. So it was already big news, even without the overall survival data. Big news that in a population of patients who've had surgery for renal cell carcinoma, who are deemed to be at high risk of developing metastatic recurrence, this paper in a randomised trial reported that adjuvant pembrolizumab improved the disease-free survival for those patients. And it was a cracking podcast, wasn't it?
It was. We've got some returning players for today's podcast.
We do. So that podcast had our good mate Alex Kutikov, urologist at Fox Chase Cancer Center, and Toni Choueiri, first author, medical oncologist extraordinaire at Dana-Farber. And it was really good fun because they're good mates. They go back a way, don't they?
Yeah.
And it was great, robust discussion back and forth and a bit of poking fun at each other as well.
Yeah.
But I think my take on that, Renu, was that everyone recognized that this improvement in disease-free survival looked clinically meaningful. And the two key topics of, well, what about overall survival? Is that going to turn into an overall survival for these patients? Because it's clear that may not always be the case in these sorts of trials. Number two, what about the toxicity of this powerful treatment?
And the financial cost.
And the financial cost.
Yeah.
So we felt that I felt, and I re-listened to the podcast yesterday on the way home, actually, and it was very enjoyable to listen back to it and to hear some of those thoughts. But a lot of it was about, we got to wait for the overall survival OS. We got to wait for the OS. We got to wait for the OS. So here we are with the OS.
Finally, it's here. You know, do you remember the debate you and I had at ANZUP last year? And I had to debate you to convince everyone that we should use adjuvant pembrolizumab. Tony, I wish you'd published this paper like 6 months ago.
You still kick my ass, mind you, it must be said. There was
but
a big
I really had to work hard for it.
She won. So we again have a couple of fantastic guests back. We're welcoming back a returning hero from that first one, I thought, as the urologist. Alex Kutikov from Fox Chase is joining us again. And he's joined by his colleague at Fox Chase, Matt Zibelman, who is a GU Medical Oncologist who has a lot of experience in adjuvant trials in renal cell carcinoma. So right. Alex and Matt, thanks very much for joining us.
Welcome.
Thanks for having us. Listen, Declan, I'm going to blame anesthesia as usual, but I was going to bring my even bigger picture of Toni that was going to be behind me right now, but I had to be, sort of doing it outside of my personal office. So just trust me, the picture of Toni just gets bigger and bigger in my office.
Now it's like it's got a garland around it and everything, right?
So if you missed that first time around, we'll flash it up on the video here. But he kind of hijacked the discussion a few minutes in by taking this picture off his desk behind him of Toni Choueiri. It was like a part of a shrine to Toni.
It was a small one. Now it's half my office. Yeah.
It's got bigger. Oh man, you might even get an autograph one day.
Maybe.
He did say that at the end of the podcast. Next time, if you get the OS, I'll bring back a bigger picture. So yeah,
it's on. Next podcast, bigger picture, Toni.
Oh my God.
And Toni couldn't join us today. He sends his best wishes on this. And in fact, I remember the day the OS data came out, he flicked on the media release to us to say, hey, Declan, Renu, here it is. And you, Alex, you were copied in OS. We'd love to come back and talk about it, but we just haven't managed to engineer it for today. And we wanted to get on and talk about it. And I should, before I welcome Matt, I should also say this podcast is a themed podcast supported by our friends at MSD, who are behind this drug, of course. MSD have actually been great supporters of our podcast. They've been silver partners since the get-go. Baz and team, they recognize the value of podcasts in supporting GU oncology education. So this is a themed podcast, which means it's still our usual unrestricted educational content, but we're grateful to them for supporting everything we do here at GUcast. Sure. Matt, welcome. Thank you then for filling the shoes of the GU Medical Oncologist in this really important discussion on adjuvant immunotherapy for renal cell carcinoma. Thank you for joining us. You're very welcome.
Yeah. Thank you so much for having me. I appreciate it. I don't know that I can fully fill Toni's shoes, but I do have a lot more hair. So,
You said that.
He will be listening to this. That's good. We might as well have the usual barbs anyway. He'll enjoy that. Yeah. So please check out Matt's fabulous mane on thing. Now,
and you have a lot of experience in this arena, Matt. I mean, you're a co-author on the IMmotion trial, right. And so I mean, this must be really big news in the field of renal oncology.
Yeah, I think as you guys have outlined, this is something that we've been waiting for quite a while, and to actually have results that I think are meaningful for our patients, I think, makes a big difference. And it's certainly been a big topic over the past year or so.
Yeah.
So we thought we'd chat first of all a little bit about the background to why this is an important population. And we have a real mixed audience. There's lots of urologists and urology trainees, but a lot of GU, med-oncs, rad-oncs, and a lot of patients listen to this podcast and industry people. So we want to chat just a bit of banter first, Alex, about the background to why we should even be interested in adjuvant treatments for renal cell carcinoma. And then we're going to ask Matt to talk us through the trial, give some high-level summaries of the trial. So that's the first topic. You do a lot of kidney cancer surgery. I don't do kidney cancer surgery, but these patients with T3 cancers and so on, or higher grade T2 cancers,
sarcomatoid, these awful renal cancers, and you do, after you do surgery on these patients, you do wish that there was something that they could get. I mean, that's a common thing we hear from a lot of urologists for that particular patient with the particularly nasty kidney cancer. There just seems to be no other option but to wait for the recurrence to happen.
And there's a sense of doom sometimes, Alex, isn't there, with these patients? They know that. They say, oh, what are my chances of recurrence? And they will ask that question, and you give them some prediction. Oh, all right, I'm just waiting on that next scan and that next scan. So some sort of adjuvant treatment has been an unmet need, it's fair to say.
Oh, absolutely. I mean, there's basically a graveyard full of effort in the adjuvant space on kidney. Here at Fox Chase, the Assure trial was, spearheaded by Rob Uzo here, who's now CEO of the hospital. And, that was, Matt, 15 years ago now. Yeah. Trial after trial after trial has been just absolutely negative, no signal. And here is, really a home run, and it's very exciting.
Sure is. I like that graveyard of effort.
Yeah, it is, isn't it? It's true. Well, that's the nature of clinical trials in oncology. In everything, I suppose, it requires a lot of effort from investigators, and especially for patients to commit to it. So having a successful trial is great. But shall we ask Matt to talk us through this?
I think we should,
It's called Keynote 564. K564 people will refer to it as, and it's a proper landmark trial. I think of all the trials we've seen in renal cell carcinoma in our career, this one already is up there at the very top of this is a landmark trial because of the importance of the findings. So Matt, talk us through a bit.
Yeah, sure. So Keynote 564, this was a phase 3 double-blind randomized placebo-controlled trial, which I think is important. It was done internationally. The primary endpoint was disease-free survival, but OS, or overall survival, was a key secondary endpoint. Eligible patients, and I think this is relevant, especially as we might talk about some of the other trials in this space, included patients who were T2 and grade 4, T3 really at higher grade, and then either N1. And then they also allowed the patients who were M1 and NED, but notably they had to have had their metastatic site resected within 1 year of diagnosis. So I think that's important. Patients were randomized 1-to-1 to receive Pembro every 3 weeks for a year to placebo. And that was, basically the design, somewhat similar with some significant differences to some of the other trials. Do you want me to go through some of the high level results, and then we'll kind of go from there?
Sounds good.
Right.
Yes.
So I think for urologists or for patients listening, that's a pretty common situation. Yeah. These are patients who they've had a nephrectomy and it's T2 cancer, but with nasty looking grade 4 components. It's a relatively small proportion of the trial, actually. I remember Toni clarifying 10%, but the majority of patients are PT3. So there's some evidence of this is going into the fat or into little blood vessels, so a higher risk of recurrence. So every day in hospitals around the world, patients are coming back into the clinic to be told this is the type of cancer you have on your kidney that was taken out last week. And so that's the population of the study, I think. Anything else to add to that?
Matt, I've always been curious. So, there is this small subgroup of patients who have M1 NED. So these are patients who've had metastatic disease that's been resected, and there's no evidence of disease now on imaging. What is the rationale behind including these patients in with the other patients who have localized disease? Do we believe that they're really the same population that we're studying?
I think when these trials were initially designed, there was some uncertainty about those patients and how to include them. And there's a push and pull about getting adequate accrual and getting enough patients to be a part of this versus really having a very sort of homogenous population. And I think ultimately all the trials sort of took that a little bit differently. And I think there is a difference between the patients included on this trial, which had to have had a resection of a metastatic site either at the same time or relatively quickly after their primary, versus IMmotion, which allowed patients had to have had their resection of a metastatic site at least a year after. And I think by nature, patients who metastasize early are going to be inherently, more aggressive, higher risk patients versus those that have maybe a slightly more indolent kidney cancer where the recurrence happened at least a year out. And so I think those are probably slightly different patients and not totally comparable.
Yeah. All right.
I think you have to. I mean, the rationale is really, you have to remember that, if you take your, say, PT3A, say grade 4, the recurrence rate is about 50% after, depending on what nomogram, from 50 to 75%. But, Liebowitz nomograms, that's 50% recurrence rate. Whereas if you take, solitary adrenal met and you resect it, your disease-free survival at 5 years is about 30%. So they're not too far off, right. If you sort of, group them together. Whereas at the same time, that group of, sort of M1 resected is also heterogeneous. I mean, the, lymph node positive disease is far worse than sort of solitary adrenal met. Right. So there's definitely a challenge there as well.
Yeah. We should talk about the results.
Yeah.
That's where the money is.
Yeah, so results. So the trial ended up including almost 1,000 patients that were randomized. Median follow-up in the publication is a little under 5 years. Median overall survival was not reached in either arm, but they did present landmark OS and DFS. I guess I'll go right to OS since that's really the big part of the discussion here. So the overall survival did show an improvement. There was a landmark improvement at 4 years from 86% in the placebo arm to 91% in the pembrolizumab arm. So an improvement of about 5% absolute at 4 years. Hazard ratio was 0.62. Update on the disease-free survival, just so we sort of have that for completeness. At 4 years, it was 56% disease-free survival in the placebo arm, 64.9% in the treatment arm. Hazard ratio was 0.72. So about a 9 to 10% improvement in disease-free survival at 4 years.
Yeah, wow. So they're pretty big landmark figures, Alex, isn't it? You can sit there saying to your patient, we now know with your PT3 cancer, 50-odd% chance of recurrence over the next 5 years. If you have a year of pembrolizumab, we'll come to the side effects in a second. Yeah, this is going to reduce your risk of dying from that cancer by, almost 40%. It's pretty big, isn't it?
I think so. I mean, I think, the arguments that I made before we had the overall survival data were, listen, you're going to overtreat 50% or more of patients, right? Because they don't need it. And then you're going to undertreat the patients who do need it because those, doublet therapy is really the standard of care. And you're only given, a single IO agent. So that was the argument. Now, I think that argument changes. I mean, you have prospective randomized data, and we'll talk about some of the sort of, challenges to these data. But I think we have to remember this is as well a performed trial as you could have. And in the very least, for every surgeon, I think it's mandatory now that these data are presented. And I think there is definitely sort of a little bit of surgical machismo that goes in here. And, we just did a big surgery on you, you're cured, high fives, and, we'll just watch you. But I think now it behooves all the surgeons to really send to our medical oncology colleagues for an objective and balanced counseling and opinion here. And, this, I guess we'll get into it in a second. Does every patient need it? Maybe not, but every patient needs to know about this and need to look into it and understand it.
Yeah, I mean, it'd be a huge change in practice, wouldn't it? I mean, urologists really are the gatekeepers of these patients, and it is going to take a huge change in what we normally do to now tell these patients. Because I mean, when I see these patients in clinic, one of the most common questions I get is, "Do I need anything after surgery?" And now
the answer has always been no. We're just going to watch you.
We'll just watch you. That's all you need. But now we've potentially got a very different answer for them.
And that's a lot of urologists listen to this podcast, and of course it's not widely fully available yet, but it's coming quickly. I think all around the world, and we can update on that. But I think here in Australia, we'll probably have an early access program this year, probably within months, and we'll probably have full proper reimbursement next year sometime. That's our anticipation. So we need to get the urology community and patients ready for this, more so the urology community, because undoubtedly, Alex, I'm sure there'll be situations where we won't have that conversation. The patient will just not be followed up as usual. We'll develop metastatic disease like the control arm does. And we can talk in a minute about, the salvage opportunities and the control arm of this trial. We want to talk about that, but we do need to change urology mindset so that doesn't happen. That we're not seeing a patient in a year time or 2 years time who never had that conversation when they could have had it. So what else can you say about that? I mean, podcasts are helpful and courses are helpful, industry stuff are helpful, but it's a really important change for the mindset of urologists who do kidney cancer, and we need everybody to know about it, not just people in big cancer centers.
For sure. I mean, I think, we all go to urology meetings, and urologists love to beat the drum of prospective randomized trial. Here's one. We're very good about ignoring level 1 evidence. And here's evidence that shouldn't be ignored, in my opinion. I mean, this is, we'll talk about some nuance here, but I think this is, very actionable in practice. And I think, if forget anything else, just send, get a colleague, partner, Matt and I have shared a ton of patients together. He does a tremendous job sort of counseling, sort of the trade-offs and the risks. And, each patient can make a balanced and, sort of objective decision, like I said, but most importantly, a well-informed decision that is, and I think a surgeon who just operated on the patient, in my opinion, is a little bit biased.
So, Renu, in a minute, we want to talk about 2 really important things. One is the control arm of this trial, because there's been lots of discussion about that. The fact that not all the patients in the control arm did nobody crossed over, but they didn't get access to combination IO, etc. So we want to talk to Matt about that in a second. And the second thing we want to talk about is the toxicity of pembrolizumab and so on. But before that, Matt, as we said at the start, you have a lot of experience in adjuvant trials in this setting. And can you please just give us the take home on this? Because a number of other trials, including the IMmotion trial, another very good prospective trial that you're an author on, of adjuvant atezolizumab, published in Lancet Oncology, didn't show a benefit. So why is it that other trials have failed and Keynote 564 has succeeded? Before we go and talk about the control.
We were asking this when the PFS benefit came out.
But because we were
now
skeptical.
We're particularly asking this.
Please explain.
Every other trial's not shown this. What's unique about Keynote 564?
So I wish I knew all the answers to this. I think, I'd probably have my own podcast if I knew for sure what the answer was. But I think a lot of it comes down to trial design. And I think there are important differences between all of these trials. And I think the sort of combination of those differences in the patient populations and the designs, I think ultimately led to the slightly different outcomes. Just to name a few, as you mentioned, I was a PI and an author in the IMmotion study. That trial used a different drug, atezolizumab, that was a PD-L1 inhibitor. There does appear to be maybe some slight differences in efficacy between PD-1 and PD-L1 drugs. And if you look at that trial, there was a definite difference, at least numerically. Of course, always hard to compare cross trials, but the disease-free survival rate was different in that trial, despite the control arms being somewhat similar. So there did seem to be a little bit of difference there. In the Ipi-Nivo trial, which in some ways may be the hardest to explain, because we would all think using combination immunotherapy, right? More is always better. So why didn't that trial do better? I think one drawback from that study is that they only gave 6 months of the adjuvant PD-1 drug, and maybe there really is a difference between 6 months and a year. And I think the toxicity of the combination therapy may also have played a role in maybe why those patients didn't do quite as well. And then I think if you just look at the patient populations, the Keynote trial somehow managed to get the most T4 patients, sort of the highest risk patients compared to the others. They had the most sarcomatoid, and those are patients that we know are likely to respond to immunotherapy. They did not include any non-clear cell patients, which are maybe more inherently not as sensitive to immunotherapy, whereas some of the other trials did allow some of those. And then back to the M1 NED issue, they brought on the M1 NED patients who are probably the most likely to benefit, because these are the aggressive patients that had an early recurrence, and giving them adjuvant probably worked very well. And you see those patients did well immediately. There was a separation right away. And, that was not the case in some of the other trials. So I think when you put all of those things together, that potentially really accounts for why this trial succeeded where the others didn't.
I was just going to say, I would add, go back to Assure versus S-Track, right? That's the adjuvant sunitinib trials. One was negative, one was positive. And you can sort of dissect the difference there. Like Matt said, S-Track, investigators went back to test sunitinib in the adjuvant setting. and enriched. It was, I think it was 99% clear cell in that group, and it was 100%, T3 to T4 patients, whereas Assure, only had 80% clear cell, had some, T1, T2 patients that weren't really high grade. So once you enrich for the higher risk patients, you get a higher signal. So trial design is very important here. And, just to remind the listeners, S-track was positive for, disease-free, progression-free survival, but wasn't positive, overall survival hasn't been reported. So that's the only other positive adjuvant trial that, did get FDA approval in the US, actually. Didn't get much traction, but got FDA approval.
Yeah.
Got the approval, but nobody used the drug, I understand. So that's interesting, isn't it? But it's going to be a very different experience with this one, isn't it? Absolutely. It seems very different. And even listening back to the difference in opinion from 3 years ago to now with the OS, and listening to Matt's explanation, because a lot of that time, I remember back in 2021 when the first paper came out, there was a huge amount of focus on, well, why is this one succeeded and the others have failed? And is it the control arm? We want to talk about that next, don't we? But I think a lot of those arguments are falling away because of the strength of the evidence, aren't they, Renu? Yeah.
And Matt, do you think within the class of PD-1 inhibitors, nivolumab versus pembrolizumab, do you think there's a difference between the two drugs when it comes to efficacy?
I don't think there's much of a difference. I think probably they both perform pretty well. They both had some successes and failures across different diseases, but I think overall they're probably fairly similar and comparable drugs.
Yeah.
Okay, control arm.
And we have to remember, look at nivolumab in bladder, right? No overall survival advantage, just progression free. No controversy. Everybody uses it, right? We have to keep that in mind.
Just because we do,
it's gotten traction.
Yeah.
But we want to talk about the control arm, because we had a load of chat about this the last time, Alex, didn't we? So basically, in this trial, the control arm, correct me, Matt, if I'm wrong, was placebo. So everyone's on placebo and having regular scans. And then when they progressed, if and when they progressed, which is I think about half of them, it was up to local investigators, and this was a multi-center trial worldwide for what standard of treatment. In other words, they didn't cross over, which is fair enough, I suppose. There wasn't enough data to do single agent Pembro at the time. But they didn't necessarily cross over to what was becoming standard of care, which is doublet IO VEGF, I suppose. So people like me and others will say, well, it's a bit like post-operative therapy, early versus salvage. We know that if you have high quality early salvage, then you don't need to have adjuvant, and you save all these people from unnecessary adjuvant treatments. So is it still a reasonable question for me to ask that if all of the patients who progressed in this study did get access to standard of care combination IO, and maybe you'll tell us how many actually did, that there might be a very different trial, because nowadays that's what people would be getting at progression. So would they be better off just waiting and then half the people don't ever get treatment? Or is that an argument we don't need to have?
Well, maybe I'll start. And I think I would take issue with standard of care. I think to say that, progression to oligometastatic disease, getting doublet therapy, standard of care. And, I'll defer to my medical oncology colleague in a minute, but I would argue that's not quite the standard of care yet. There's 2016 trial, phase 2 trial, Brian Rini and Betsy Plimak showed that, with oligometastatic disease, you can defer systemic therapy for a median time was 14 months in that phase 2. So I'm not sure that the minute you have your small lung metastasis, that's actually the standard of care. So I'm not, I think that's holding this trial to a standard that actually probably can't be justified. That, that they should have immediately at, first metastatic site gotten some doublet therapy. And plus, you have to remember, this is make sure I get their years, but 2019 Pembro was approved, right? Mm-hmm. And this trial closed, right? So, this is, you're asking, sort of investigators to turn the world around for something that, that really wasn't the standard of care, and is still not the standard of care to treat oligometastatic disease immediately. Matt?
Yeah, well, I think, I agree with what Alex says. And I think the assumption that I want to be careful of is we shouldn't assume that every single person that recurs immediately needs to get immunotherapy. And I think that's what sort of rephrasing somewhat what I think Alex is also saying, because there are other options for some of these patients. And even if you look at this trial and the subsequent therapy, in both arms, about 20% of patients didn't get any subsequent therapy. So presumably some of them went on observation, some of them got other sort of treatments, similar amounts got radiation, got surgery. And if a patient has a oligo recurrence, 2 years out, doing some sort of local therapy for that may be very reasonable. And not all of those patients need to get checkpoint inhibitor. And the other point, Declan, you said something about access to care. And I think the assumption has been that, this international trial is being done in countries that can't afford or don't have access to therapy, that's maybe somehow done on purpose, and that is part of the sort of approach for these sorts of trials. I don't know that we know that yet. It's certainly possible that some of these patients don't get it. One of the questions that was asked at GU ASCO that I think is a really good one is, can we get the data of patients on the placebo arm who died without ever receiving checkpoint inhibitor? Right, that really might be a tangible measure of who actually didn't get access or didn't get subsequent treatment that they maybe could have had. And we really don't know that data. And some of these patients may still go on to get, and I suspect will go on to get, checkpoint inhibitors. So it's absolutely reasonable to look at that. And I think it may be a factor, but I don't think it's as cut and dry as 100% of people who recur should get a checkpoint inhibitor.
Yeah. No, and I think it was about... It was about 48% who got a checkpoint inhibitor, but you're right. A lot of people didn't need it, didn't get access to treatment for various other legitimate reasons.
Yeah, and I mean, maybe you can put up what is it, like figure 1B? I think it's in the New England Journal paper.
Yep,
I mean, we have, like Matt said. I mean, I think there's going to be more data coming out. We'll get some clarity on this, but I think even looking at it here with the data that we have, where they have the geographic region breakdown, right? It looks like your hazard ratio for death for US was 0.68, and for outside the US was 0.61. So the difference wasn't huge. And actually the number in the US was small, and there was a very wide confidence interval. So, even in the US where, as you assume people would have gotten, standard of care or whatever, quote unquote. I mean, there was a signal. So I think, and also, I mean, we have to remember adjuvant. So adjuvant, what's the difference between adjuvant versus salvage? I mean, adjuvant is you have the patient captured right there in the moment. They just had surgery. They're engaged. They're emotionally invested, and you're sort of getting them to the next step of therapy. Whereas, perhaps we're seeing sort of natural traction of people getting lost to follow-up here, and even within a trial, and not getting salvage therapy. I mean, some of this is real people having real lives, and they just they recur and they don't get to therapy in time, or for a while, especially if they have oligometastatic disease. So I think expecting everybody in the control arm to get doublet therapy the minute they recur, I don't think that's realistic.
I agree with you.
Yeah.
I do agree with you, and I think that's a really very fair rebuttal of that argument. And I know I've made that argument in the past, but I completely softened. I totally agree with you, actually. And even we've just had our tumor board meeting at Peter Mac this morning, our MDT meeting we have every week. Every week we have a couple of low volume recurrences, and very good GU medical oncologists. Our Matt Zibelman's, Luisao and Lavinia Spain will just watch. Of course, these are asymptomatic patients with scan-only disease. It's perfectly reasonable to do that. And I don't think it undermines at all the argument for adjuvant Pembro, single agent Pembro. We'll talk about the side effects in a second. So I agree. And I think there are some vocal critics out there who really have a go at the control arm, much more than we might just have genuine academic critiques of it. And I think what you've just said is a very fair rebuttal. I don't think there's a problem with the control arm.
I think we have to level set the scale here. The scale of the effect. I mean, it's 38% overall survival. I mean, if you look at the historic, breast, colorectal, melanoma, even GIST adjuvant trials, I mean, your overall survival benefit was 4, 6, 5, 3, 1%. I mean, or 0. I mean, that's what we're talking about. Here we have almost a 40% overall survival benefit. I think it's insane that we're so critical of this trial. I mean, I think Toni deserves huge kudos for bringing this forward. And I mean, the static is like ridiculous, to be honest with you. I mean, I mean, I've heard it, and it's just, it's just upsetting to me that this was one of the best adjuvant trials done in any disease space, and it's getting a lot of flack for no reason. It is as good of a trial as it gets, and there's never going to be a better trial here.
I don't think it's getting that much flack. I think there's a couple of vocal critics, but I think even compared to the adjuvant side, I don't know what Matt thinks about this, but I mean, I think there's some genuine academic criticisms, respectful out there, and then there's maybe some more over-the-top criticisms, but I think that's the minority. I think my sense is it's very well received, and this data in particular compared to the original data is very compelling. So I don't think there's that much criticism. I think we all hear it from certain quarters, but it's a minority view.
Yeah, and I think we all appreciate that, in this generation, it's one of the biggest impact trials, and it's going to lead to a huge change in practice and ultimately benefit for our patients. I guess the question is now, how do we translate this into the real world? And Alex, when any patient who fits the keynote 564 criteria, would you then refer to a medical oncologist for discussion? Would you be discussing it at a multidisciplinary meeting? How do you go about this? And we have to remember that not every urologist is in a tertiary academic center where these patients can be discussed at a multidisciplinary meeting. Do they all just get referred off? Where does the decision making happen?
I mean, I think it happens in your post-op visit when you review the path. And I think if this is a patient with T3 disease or T2 grade 4 disease, or fully resected on one disease. I mean, all the patients that were eligible for this trial, I think should hear about this trial and should get referred. That's my opinion. Now, I mean, I think there are edge cases on both sides of the spectrum. I mean, I just honestly had a patient a few weeks ago who had a 3-centimeter renal mass that I resected. It was T3, A, and some small venule that was, on pathology T3A. I'm not, yes, he fits. I sent him to discuss with medical oncology, just, to be true to what I, to practice what I preach here. But, do I think that patient is really in the spirit of this trial? I don't think so. Whereas I think the other end of the spectrum, you take out these very bulky, large sarcomatoid renal masses. And yes, I'm going to throw the kitchen sink at them because I just, I know they're going to recur. And there's a super high risk patients. I want to give them every chance we got. And we have, as good of evidence as it gets that in the adjuvant setting, there is a survival benefit.
Yeah. I mean, I think you're right. There's almost two pools of patients, when you see them in the clinic. There's the patients, everything in your gut tells you this is a patient that needs adjuvant treatment. But then there are those, T2, T3A, just like the ones you mentioned, where there's just a little bit more resistance in exposing them to adjuvant pembrolizumab. But I mean, I think this is where then the discussion needs to be had with them, so they can fully weigh up the risks and benefits. And I guess, Matt, this is where you come in. A lot of patients want direction. It's hard for them to make a decision. How do you counsel them, especially regarding the toxicities of treatment?
Yeah, so I think this is first off one of the most nuanced, difficult discussions I think I have with patients. And full disclosure, I probably just as often as put patients on trials or give them adjuvant therapy, have them decline it or maybe even scare them away because I think the toxicities of these are real. And so I do think it's a difficult discussion. Patient selection is, I think, really key and really helping patients understand what the risk of recurrence is and try to balance that with the risk of immune toxicities and downsides. And, to your question, I think I really try to give the patient as much information as I can to help them make the decision that's best for them because, some people will perceive their risk of recurrence and the risk of side effects, I think, a little bit differently and weigh those differently. And, some will want to do, everything I can to try to cure my cancer and they're going to want to get treatment no matter what. And then there are others who, when I talk about 10 to 15% risk of serious immune toxicity, some of those maybe with long-term morbidity, that will cause complications for the rest of their lives. I think that's real for patients and not everyone is willing to go that route.
And that brings in the conversation about toxicity, I suppose. That's the last big area we want to pick your brains on, Matt and Alex, is obviously having treatment.
Can I just add one more thing here?
Sorry, Alex.
Yeah, this also, I think it depends on the patient, and I think it depends on people's outlook on life. And I think, as you know, we meet patients and they just have a very different outlook. And I mean, this is even before the overall survival advantage, right? Even when we just had S-track, this was a decision. Taking a drug for a year to be disease-free for an additional amount of time, is that worth it to you? And for some people, that's really worth it. I mean, we talk, in prostate cancer, we measure quality of life, quality adjusted life years. I would argue that knowing that you're metastatic, that really reduces your quality of life. And you can balance that with toxicity, because toxicity actually, obviously reduces your quality of life. But the knowledge that you have metastatic disease versus not thinking that you're disease-free, I think that's a big difference. And for some patients, that is a huge deliverable, even if there is no overall survival advantage, and it appears that there is.
So toxicity. So a group of well patients after surgery who have no metastatic disease, and you're going to offer them adjuvant treatment. Obviously, the bar for tolerability and toxicity is higher, isn't it, than for patients who have metastatic disease and need treatment. So that's what we want to finally focus on, is what is the tolerability, the adverse events of Pembro in this population. Now, I think we're all reassured that, of course, there were no deaths from Pembro in this. But Matt, can you talk to us a bit about the serious toxicity of the Pembro and leading to discontinuation, or what sort of side effects do these patients get if they do get serious side effects?
Yeah, so this is a big interest of mine, side effects from immune toxicity. And what we saw in this study is certainly in line with what we expect from these drugs. About 20% of patients discontinued for adverse events. Grade 3 to 4 adverse events were reported in about 18% of patients in the treatment arm, and they recorded immune adverse events as 36%, although it's hard to know what is recorded as immune and what's not. And, really the only side effects we expect from these really are essentially immune adverse events. So those are the numbers, and I think they fall in line with what we normally see. I'll say what I usually quote to patients is to expect an immune adverse event rate of about 10 to 15%, at least serious adverse event that requires me to do something. And most of those will be treatable and reversible for patients, but there will be a small percent that aren't, and that will lead to long-term morbidity of some fashion, sometimes serious. And that's the hard part to sort of really help patients fully understand. And I think giving these is different than giving sunitinib for a year, where it's nuisance toxicity that patients get, which definitely affects quality of life, but you stop the drug and it goes away. And really the same with chemotherapy when we give that in other diseases for adjuvant therapy. It's a more predictable timeline. Immunotherapy patients can feel great with nothing for 6 months and then all of a sudden have a severe immune side effect. And so it's just it's a harder discussion and a sort of a harder concept, I think, to help explain to patients.
What about some of the side effects like colitis, diabetes that may be, a little bit more permanent afterwards? How do you tell patients about that, and how do you help them balance the risk?
So what I tell patients is a lot of the time is any itis that you've ever heard of, whether it's colitis or nephritis or hepatitis, can happen to you. And we have to look out for all of them. Things like rash, so dermatitis, colitis, those are some of the more common. Of course, endocrine toxicity is like hypothyroid. And I just tell them, we might cause damage to your thyroid gland. It might stop making hormone, but we can fix that. I can give you a drug to replace that. You have to take a pill the rest of your life, but we can fix that. So I'll talk to patients about some of those more common, but also very treatable immune adverse events. Colitis is something that most patients we can treat and reverse relatively easily nowadays. And that's the case with a lot of these. I think the ones that we worry about the most are sort of the less common but most serious ones: myocarditis, pneumonitis, myasthenia gravis. I've seen those toxicities in patients, and I've had some bad outcomes. And particularly in the adjuvant setting, that is really not what you want to see. It's one thing when you're giving these drugs in a metastatic incurable patient, and you're somewhat willing to accept potentially serious toxicity. It is different in the adjuvant setting. And so I think that part of the discussion is always something that I think is important that we tell patients about. They need to know that so that they can balance that. But is also just part of the reality of giving these drugs.
Yeah, Alex, that's not a conversation for urologists to be having, I think it's fair to say, but we need to have some knowledge of it, don't we, for when we have that preliminary conversation to say this is what your pathology is showing, and look, there's this amazing data, but I'm going to refer you to my colleague who's an expert in this, and he or she is going to talk to you about this, that, the other. But I think it's important we understand the nature of immune side effects and understand the treatability, and people like Matt are expecting them and watching for them. And it won't take away from the huge OS thing, but it just means that conversation is a very, has to be a very balanced conversation, well-informed patient, etc. And so, what do you think a urologist needs to know? What are the simple things a simple urologist like me needs to know if I'm referring someone on for
Pembro
a discussion
101
about adjuvant Pembro?
Well, I'll say to Matt that one thing I've learned from my medical oncology colleagues, but I think every urologist should understand and know. If somebody you have a patient, whether they're metastatic or whether they're on adjuvant therapy and they're on IO, and you get a call from the ER, they have pneumonia. If they don't get steroids, they will die. Make sure they're not sitting there getting antibiotics in some outside hospital. Call your medical oncology colleague. So,
For sure.
I love it. Now, the last thing, Renew, is, and we talked a bit about, cost. We want to talk about cost, don't we? And just finishing on the education thing, something struck me is, we're working on this, and our colleagues in industry at MSD, at Merck, Sharp Dome are working on it. And I know you chaired an ad board last week, so you're trying to do some efforts to educate urologists in conjunction with GU Medical Oncologist about this. And then there's some symposiums coming up. We got Raina McKay coming down in a couple of months for a big symposium to talk about this. So have you any other thoughts on the education aspect before I know you want to talk about cost?
Yeah, no, I mean, I think it's, it's important for urologists to be aware of this data, and I think it's important for urologists to be advocating this, because that's going to really make the difference in terms of referral basis. And, this is compelling data. It's really not right for us to sit in front of a patient and say, you've had your surgery, that's it. They should at least be referred for a discussion. And I think that's a really important thing to make sure every urologist is aware of.
Here. Now, final thing, dollars, because this is going to be expensive now, isn't it? And I remember, Alex, we spoke about this the last time, about the frightening cost of this. It's not like tamoxifen, as you were saying, costs a couple of bucks, but it's expensive stuff. So, here in Australia, things are always very highly considered like this. But I think the OS will convince the reimbursement bodies to come to this. But ultimately, the taxpayer will end up paying for it. We're all getting older. There's all these amazing treatments going to make us live even longer and have more expensive conditions that need treating. But it is expensive. Someone has to find the money somewhere if we're going to be offering this.
Yeah, what's the situation like in the US, Alex and Matt, in terms of making this drug accessible and affordable?
Ours are up to $100 bills here, so I'm not sure
I mean, the drug is approved, and so payers for the most part will pay for it. There's no doubt it's expensive, and it is a lot of money for a year of pembrolizumab. And I think that is a really difficult thing to weigh. Sort of how much is too much when you're potentially curing some percentage of patients. Certainly for that individual patient, nothing is too much. But it's a really hard thing to weigh. But I do think it's an important question, because we're only going to get probably more and more of these expensive drugs, in these and other areas. And so we do have to, at some point, pay the bill, and understanding where that fits, I think, is relevant. I don't think I have the answer to that on this podcast today, but it's definitely a question that we're going to have to continue to grapple with.
Yeah.
And on a practical point, Matt, what is the dose, and is it how do they take it? Is it?
So pembrolizumab is intravenous. It's infused on the trial. They did every 3 weeks for a year. So the 200 milligram every 3 week dosing. I think that there is also a every 6 week dosing that is, approved and used at least in other settings for pembrolizumab. And I think that is reasonable. Now it's double the dose every 6 weeks. So I don't know that you're saving money giving it that way. We're saving some chair time and time for the patient having to come to the hospital if we give it every 6 weeks. But it's infused every 3 weeks for a year, and there's definitely significant dollars associated with that.
Yep. Well, there you go. It feels like we've closed the book on. We've got part 1, part 2 of this keynote 564 trial, which was very enjoyable first time around with Toni and Alex, but even more enjoyable this time around with Alex and Matt. I just feel there's a real closing on this argument now that, okay, this is clearly successful, clearly landmark, clearly great for patients. I don't know. What do you think?
Yeah, absolutely. I mean, and I think the overwhelming, I was on that ad board with MSD last week, and the trial is received very well. It's good data. People are convinced. I don't think urologists will take much convincing.
Yeah, I don't think so either. But we have to get on a mission, and I am concerned, as I mentioned earlier, Alex is too. That we'll be sitting here seeing a patient in 2 years' time who's been referred with metastases, or hopefully not one of our patients with metastases. And it would have back in late 2024. Post-surgery, they could have had a conversation. So if you're out there and you look after these patients, just be very, very aware of this. And as it becomes available and reimbursed in your setting, please make sure you're referring on to your GU Medical Oncology, your Matts and of the world, and Toni. And final word of congratulations, I suppose, to Toni and senior author Tom Powell's. We should give a shout out to Howard Gurney, our Australian colleague. This ran in Australia as well. Howard's a medical oncologist in Sydney who's involved in the trial as well. But so over to you for final comments. Alex, anything else you want to sign off on as we close the book on Keynote 564?
I just really like to second the congratulations to the investigators. I think this is a huge contribution to the field, and huge kudos.
Absolutely.
And Matt?
I think it's really exciting data for our patients, most importantly, and I think hopefully we'll have more success in this space with some of the other trials and can improve on the survival benefit that we see here.
I love it. Great.
Should also mention Tom Ferguson, who is another Australian contributor.
Oh yeah,
co-author.
this as well. Yeah, it's great. Well, congratulations and well done to all the patients who participated in this as well. It's obviously really important stuff. It's really important data. It's practice changing. Really, really important. Please, we'll put the links in the show notes to the trial for people who haven't read or look for more coverage. But it'll be hopefully coming soon to availability near you. That's all we have time for on this episode of GU Cast. That's all from myself and Renew. Thanks again to our friends at MSD, our silver partners who are supporting this themed podcast. Thank you.